My name is Uqba Khan. I'm a medical oncologist and I focus on GI malignancy. I work in New York City at New York Presbyterian Hospital, Weill Cornell Medicine. So it's really a pleasure to be here, and thanks for the invitation. So today I will be talking about localized and metastatic colon cancer. So these are my disclosures. So colon cancer is one of the very common cancer, and probably in your practice you see that very commonly. It's globally it's the fourth most common cancer that is diagnosed, and there's an unfortunate truth about it that in younger patient population we are seeing this cancer, and there's a rising incidence. We were just talking that in our clinics we are seeing patients as young as they're in their young 20s, 30s that are being diagnosed with colon cancer. So that's why the screening has been changed to 45 years. It used to be 50 years. So please ask all your patients to get screened at the appropriate age. There are many risk factors for development of colon cancer. Of course, it has to do with the genetics. In younger patient population, if you look at the population data, there's about 30% of the cases where they will have some genomic or germline mutation, but vast majority of them will not have any underlying mutation. So the other causes for the development of colon cancer, obviously it has to do with the environmental factors, the diet, the processed meat, the alcohol intake, lack of vegetables and fruits in the diet, and then other toxins like smoking, and the previous history of inflammatory bowel disease. So these are some of the common causes, not causes, or the risk factor I should say, for colon cancer. Before we talk about the management, I think it's very important to differentiate the left side versus the right-sided colon cancer. There are certain differences between the right and the left-sided colon cancer in terms of the biology, but also more importantly in terms of the outcomes and the way we treat them, especially in the metastatic setting. In the right side colon cancer, which include the ascending colon and the transverse colon, and the rest is the left side colon. In the right side colon, you see more of the KRAS mutations, BRAF mutations, MSI high tumors, and they unfortunately have poor prognosis as compared to the left side tumor. In a younger patient population, you will see mostly the left-sided tumors, rectal cancer, sigmoid cancer, but they can still have on the right side as well, especially if they have underlying Lynch syndrome or MSI high tumors, which are predominantly on the right side of the colon. And we'll talk about why it is important in terms of the treatment, especially in the stage 4 setting. So how do I manage early stage cancer? So typically I see those patients after the surgery. So the surgeon has already done the surgery, but in some cases I do see those patients before surgery also, especially if they are locally advanced and the surgeon cannot completely do the surgery and R0 resection. Then we typically do neoadjuvant therapy, but most of the time it's the after the surgery that when I see that patients. I carefully look at the pathology report whenever I see a new patient. I look at the high-risk features. So that will help me determine which patient should get adjuvant therapy and for how long. So for stage 2 cancer, there are certain high-risk features, and probably most of you already know. Those include T4 lesions, less than 12 lymph nodes harvested during the surgery, perineural invasion, lymphovascular invasion, poorly differentiated histology, clinical obstruction is also a high-risk feature, tumor budding, perforation. So these are all the high-risk features that increase the risk of recurrence in stage 2 cancer. Stage 3 is easy, so you just have to see whether they are T4 or N2. Either of them will put them to high-risk stage 3 disease. So now once you have seen the pathology report, the next question for you is to decide which chemotherapy and for how long. For stage 1, it's very clear. Stage 1, they have very good prognosis, so you don't treat them, you just observe them. So they don't require adjuvant therapy. For stage 2 cancer, as I mentioned, we divide them into low risk stage 2 or high risk stage 2. Low risk stage 2 means that they don't have any high risk features on the pathology report or clinical factors. So for those patients also, they also have a very good outcomes just with the surgery. So we don't offer them adjuvant therapy. In stage 2 high risk patients, the high risk features that I just mentioned, especially if they have more than one high-risk features, I typically offer them adjuvant therapy because the risk of recurrence is still, sizable. I would say about 15% or so, those patients will have recurrence of disease. So in those patients, I do offer them chemotherapy. It's a little bit of gray area which chemotherapy to offer them. But in my clinical practice, if it's a younger patient, I would offer them 3 months of Capox. If it's an elderly patient in his 70s, I will typically do just single agent 5-FU or Xeloda. We don't have good data for oxaliplatin in elderly patients, so that's why I don't give them and spare them from the side effects of oxaliplatin. In stage 3 low risk, again defined by T3 or N1 disease, I give them adjuvant therapy. It's indicated, but based on the IDEA trial, we give them 3 months of Capox. You can still do FOLFOX. If you look at the NCCN guidelines, it gives you an option of 3 to 6 months. But I typically go with Capox. It's for 3 months and you're done with the treatment quickly. For high-risk stage 3 disease, T2 or T4 or N2 disease, we offer them 6 months of chemotherapy, mainly FOLFOX for 6 months. The difference is small between 3 to 6 months, but based on the IDEA trial, the best option is 6 months of chemotherapy. If you're choosing FOLFOX, definitely 6 months. Capox, some people say 3 months may be enough, but I try to stretch it to 6 months in high-risk stage 3 cancer patients. So the elephant in the room is ctDNA. What's the role of ctDNA in choosing the adjuvant therapy? I know there's a lot of data available for the use of ctDNA in the adjuvant setting. So before we do that, let's talk about some of the basics. So stage 2 cancer, meaning node negative cancer, after surgery, roughly about 85% of the patients are cured. They don't need anything. About 10 to 15% of the patients will recur if you don't do anything. Okay, so those are the patients are high risk and they get chemotherapy. In stage 3, after surgery, 50% of the patients will be cured. Okay, but we give chemotherapy to all the people. If you give chemotherapy, there's another 20% of the patients will be cured from recurrence, okay, no recurrence, or at least for the next 5 years. And then still, despite doing chemotherapy, there will be 30% of the patients who will have recurrence of disease. But all these patients will get chemotherapy. We don't know which patient should get chemo, which patient should not get chemo. So that's where the ctDNA comes into picture. The ctDNA, or you can call it minimal residual disease. So you want to have an assay. When you do it, if it comes back positive, you just give adjuvant chemotherapy, meaning they still have the disease, you want to kill the disease, so that makes sense. And if it is negative, you opt out of chemotherapy because they're already cured from the surgery. But it's not that simple because the ctDNA technology that is available right now is not very, very sensitive. Still it can miss cancer, especially if it is negative. Okay, if it is positive, there's a good data that it is very, very prognostic for that. So at this current moment, if you look at any guidelines, especially NCCN guidelines, they don't recommend triaging the patient based on the ctDNA results, although we still do it and get some clue from it, but not entirely making decisions based on that. So based on that, so can we escalate or de-escalate treatment based on the ctDNA results? So just give you an example. So we have a T3N0 stage 2 cancer. It's clinically low risk patient, no high risk features. typically I won't give chemo to that patient. But if I do a ctDNA for whatever reason and it comes back positive, does it make sense to give that patient chemo? In my clinical practice, I would do that, and I'll discuss with the patient about that, and I think it's reasonable enough to escalate and give, adjuvant therapy. But what about clinically high-risk patients, like high-risk stage 2 or any of the stage 3 cancer? Clinically, we know that they will have a higher risk of recurrence. What if the ctDNA comes back negative? Would you offer no chemotherapy? I think it's too early to say that. I will still give chemotherapy to those patients. So it's not recommended yet. And the better answer to this is to enroll patients into clinical trials to get that answer. And luckily, we have few clinical trials that are enrolling patients into clinical trials, and one of the main one is Circulate US trial. Hopefully in the next couple of years we will have some data from it. We are enrolling patients into it, and basically it's triaging patients based on the ctDNA positivity, negativity, and escalate or de-escalate based on the ctDNA results. So hopefully in the next couple of years we'll have some data. What about MSI high cancer in early stage? So that's clear cut. So in stage 1, stage 2, you don't give any treatment. They already have good prognosis. Stage 3, based on atomic data, we gave them chemo plus atezolizumab. 6 months of chemo plus atezolizumab, which continues for 1 year. This is based on the atomic data that was presented, I believe, last year in the ASCO plenary session. And the patients were randomized, MSI high patients, after a resection were randomized to either FOLFOX, standard of care, versus FOLFOX plus atezo for a continuation for 12 months. And the data showed that there was improvement in disease-free survival. The delta was 10% improvement and at 3-year mark. So that led to the approval of atezo. All right, so that's quick overview of the early stage cancer. What about stage 4 cancer? So whenever I see a patient in stage 4 cancer, the main goal of the treatment is to improve the overall survival of these patients. It's not only the drugs, it's not only the targeted therapy, there are other things that we do to improve that, especially the surgery. Sometimes we say these are stage 4 cancer, surgery is not required. Yes, that's true, but there are certain patients where once you start chemotherapy, they will have a very good response, and then they will have some oligometastatic disease in one organ or 2 organs, which you can do surgical resection, and those patients do very well. And data has shown that their overall survival is much better than those patients who do not undergo metastatectomy from colon cancer. And over the past 3 or 4 decades, the overall survival has almost doubled. So, on average, patients can survive up to 3.5 years on systemic therapy. So whenever I see a first-line chemotherapy option for a stage 4 cancer, I put them into 4 buckets. First thing is MSI high. It's about 4 to 5% of the patients out of all the metastatic cancers. You don't want to miss that, because that's the best patient, will have the best survival. And for those patients, the standard of care is combination of nivo-ipi. You can still do a single agent if you are concerned about the toxicity, but otherwise nivo-ipi is the standard of care. Next, RAS wild type but left-sided tumors. That's why I mentioned earlier why it is important to know the sidedness of the cancer. So left-sided tumor, RAS wild type, the standard of care is chemo combination, typically FOLFOX plus EGFR inhibitor, either one, cetuximab or panitumumab. In RAS mutant, you add bevacizumab to the chemotherapy, and in BRAF V600E mutation, again it's anywhere between 5-8%. In that one, you do chemo backbone plus encorafenib and cetuximab. You can still do both FOLFIRI or FOLFOX as your backbone. There's data for both of them. So that's how I put those patients in the first line setting and triage them according to this. And these are some of the data that led to the approval of all the 4 types that I mentioned. This is the CheckMate 8HW data in the first-line setting of Nivo and Ipi in MSI high cancer. Patients were randomized to either Nivo or Nivo plus Ipi versus standard of care at that time was FOLFOX. And the primary endpoint was progression-free survival. And the initial data showed improvement in 36 months, progression-free survival rate of 68%. So that's led to the approval of this combination, and that's the standard of care. After that, the BRAF V600E mutation in first-line setting, we have the data from a breakwater study. Again, first-line setting, metastatic disease, patients were randomized to standard of care chemo versus encorafenib, cetuximab, and FOLFOX. There was another arm for encorafenib and cetuximab as well, but we'll basically mention the chemo versus encorafenib, cetuximab plus chemo combination. And clearly, it showed benefit in overall survival. So that led to the approval of this combination as the standard of care. Lastly, what about RAS wild type but left-sided tumor? About 3-4 years ago, it was a plenary session at ASCO called Paradigm Trial that randomized patients with left-sided tumors to FOLFOX plus PANI versus FOLFOX plus BEV. The primary endpoint was overall survival of the left-sided population, and it showed that the patients who receive either in this case panitumumab plus chemotherapy lived longer. The delta was about 3.5 months. So those patients live about 3.5 months longer if you give them EGFR inhibitor. Again, these patients will have some side effects from the EGFR inhibitor. Yeah. So I think I'm done with my slides. So this is just a summary slide. So again, screening is must, especially in the younger patient population. In early stage cancer, look at the risk profile on the pathology and treat according to the risk factors. And then in metastatic setting, look at the molecular profile and triage the patient accordingly and treat those patients. With that, thank you very much.